I really want you to picture the human brain for a second. If you're listening to this right now, just try visualizing your own mind as this heavily fortified citadel. It's basically a masterpiece of ancient defensive engineering.
Right, a highly evolved system.
Exactly. So you've got the skull, right? That's the impenetrable stone wall, just thick and completely unyielding. And then you have the blood-brain barrier. That's your treacherous, highly selective moat. It's only allowing the most trusted provisions to pass across the drawbridge.
And we can't forget the microglia.
Oh, yeah, the elite guards. They're constantly patrolling the grounds of this citadel, day and night, just looking for any sign of trouble. They are ready to neutralize a threat before you even know it exists, you know. This entire fortress is meticulously designed to keep the delicate electrical inner workings of your mind completely insulated from the chaos of the outside world.
It's a beautiful metaphor, honestly. But the reality we face in clinical practice is that this fortress is, well, it's not infallible.
And that vulnerability is really the core concept of our deep dive today. Because what happens when this citadel is actually besieged by microscopic invaders? I mean, sometimes the invaders are just brutal. They don't bother with stealth at all. They just batter down the gates and cause mass destruction through direct infection.
Yeah, the direct invaders.
Right. But other times, they're far more insidious. They use microscopic Trojan horses to just slip right past that blood-brain barrier moat. And then occasionally we see this really bizarre scenario where the invaders never even breach the walls at all.
This is the fascinating part, yeah.
Right. Their mere presence in the surrounding countryside causes the citadel's own elite guards to just completely panic. And in their frenzy to protect the brain, those guards end up setting fire to the city from within.
Yeah, that metaphor brilliantly captures the sheer complexity and really the varied pathology of what we're dealing with here. We are looking at how infectious diseases disrupt the brain's equilibrium. To give you the anchor framework for our discussion today, psychiatry, at its core, is the study of how the brain, the mind, and human experience interact.
Crucially, it's the study of how that intricate, delicate process can go wrong.
Exactly. And when an infection enters the picture, the boundary between neurology and psychiatry just completely blurs.
It really does. So we're going to explore that blurred boundary today using a very specific structural spline. For those of you studying or practicing in the field, this deep dive is built around Chapter 2.9 of Kaplan and Sadok's comprehensive textbook of psychiatry.
We're focusing specifically on the neuropsychiatric aspects of other infectious diseases.
Right, looking at the non-HIV pathogens.
And it is important to state for you, the listener, that this discussion is really designed as a companion to your reading. Our goal here is to help build mental models and clarify clinical reasoning. We want to understand how psychiatrists actually think about infection.
Not just memorize a list of facts.
Precisely.
Yeah.
So to do that, we'll be moving sequentially throughout this discussion. We start with the mechanism, so how these pathogens actually enter or affect the body. Then we look at the manifestation, what the psychiatric and neurologic symptoms actually look like in the patient sitting right in front of you.
And then the clinical meaning.
Right, the clinical meaning, which is how clinicians recognize, diagnose, and treat these conditions in the real-world environment of, say, an A&E or a psychiatric ward.
Okay, let's unpack this. Because to truly grasp the psychiatric fallout of an infection, we first have to understand the battle tactics of the invaders themselves, right? And it makes the most sense to start with the most relevant, defining modern example we have, which is COVID-19.
Absolutely. The modern paradigm.
Yeah, I mean, we all know it as a respiratory illness, but the systemic ripple effect it has on the brain is just profound.
It really is. So the SARS-CoV-2 virus is a positive sense single-stranded RNA virus. If we look at the mechanism of how it impacts the central nervous system, we have to start with how it gains entry into human cells in the first place. The virus famously utilizes the angiotensin-converting enzyme 2, or ACE2, receptors to bind to and enter a host cell.
Which makes total sense for a respiratory virus, you know, as those receptors are super abundant in the lungs.
Yeah.
But how does that translate to the brain?
Well, the nuance regarding the central nervous system is, it's really fascinating. ACE2 receptors are actually expressed at very low levels in our neurons.
Oh, really?
Yeah. A direct viral attack on the neurons themselves isn't the primary pathway. However, ACE2 receptors are highly expressed in parasites.
Yeah, okay, parasites. Let's define that for the mental model.
Right. To build that model, parasites are cells derived from neural crest stem cells. They wrap around the endothelial cells that line our capillaries. They physically connect the bloodstream to the astrocytes of the brain, and their primary job is to maintain that moat we talked about, the blood-brain barrier.
So the virus isn't necessarily attacking the brain tissue directly at first. It's targeting the very cells responsible for maintaining the fortress's structural defenses.
Exactly. And this leads to a really compelling speculation based on research using human brain organoid models. Because the parasites become infected, they might actually act as those Trojan horses we mentioned earlier.
Wow.
The virus infects the parasite at the blood-brain barrier, it replicates within it, and then the parasite unwittingly carries the virus deeper into the brain parenchyma, just delivering it directly to the neurons and glial cells.
It literally uses the Border Patrol as a transport vehicle.
Ah.
That is wild. Are there other ways it gets in? What about, patients who lose their sense of smell? We heard so much about that.
Yes. That links directly to an alternative entry route. There is solid evidence of direct penetration through the olfactory neurons.
So it goes right up the nose.
Yeah. Viral proteins have been detected in the endothelial cells within the olfactory bulb of patients who, unfortunately, died from severe COVID-19. The virus enters the nasal cavity, attacks the olfactory epithelium, and uses those nerve pathways as a direct bridge into the brain.
Which perfectly explains the clinical symptom of anosmia, that profound loss of smell.
Exactly. Furthermore, a leaky blood-brain barrier caused by massive systemic inflammation can simply allow viral particles to passively cross over. There's also the potential for axonal retrograde transport.
Retrograde transport meaning it travels backward.
Right. The virus essentially hitchhikes its way backwards up the nerve fibers from the periphery straight into the central nervous system.
Let's talk about that systemic inflammation, actually, because even if the virus doesn't cross the moat, the biochemical fallout is just massive. We always hear about the cytokine storm with COVID. If the lungs are severely inflamed, how does that lung inflammation actually reach the brain and cause someone to experience, severe psychiatric symptoms?
Well, systemic inflammation, particularly a massive increase in pro-inflammatory cytokines circulating in the blood, it alerts the brain that the body is under a severe threat. This activates those elite guards we mentioned earlier, the microglia.
Right, the patrol.
But they don't just passively watch. When microglia are activated in this aggressive way, they fundamentally alter the brain's biochemistry. Specifically, they drive what is called the kynurenine pathway.
Okay, I want to make sure we really understand this kynurenine pathway because it sounds like the absolute key to why people feel so mentally unwell during a severe infection.
It is entirely central to the psychiatric manifestation. So under normal, healthy circumstances, the amino acid tryptophan, which we get from our diet, is used by the brain to synthesize serotonin.
And serotonin is, of course, a crucial monoamine for mood regulation, sleep, overall emotional stability.
Exactly. But severe systemic inflammation essentially hijacks this manufacturing process. The inflammatory cytokines activate an enzyme called IDO, which forces the available tryptophan down a completely different metabolic route, the kynurenine pathway.
Okay, so if I can use an analogy here, it's like a wartime economy. In peacetime, the factories are using steel, which is the tryptophan, to build civilian cars. And the cars are the serotonin keeping everything running smoothly, right?
I love that analogy, yes.
But then when the cytokine storm hits, the government basically seizes the factories. They stop making the cars and force all the steel to be used for munitions and weapons instead.
That is an excellent way to conceptualize it. And those munitions are the downstream products of the kynurenine pathway, specifically quinolinic acid and high levels of glutamate.
Which sounds bad.
The problem is that quinolinic acid and excess glutamate are highly neurotoxic. They cause excitotoxicity, basically overstimulating neurons to the point of damage or even cell death.
So they're literally destroying the infrastructure.
Yes. And simultaneously, because all the tryptophan is being diverted to make these toxic chemicals, there is a profound reduction in essential monoamines like serotonin, as well as a drop in neurotrophins.
Neurotrophins like BDNF.
Exactly, the proteins that help neurons survive, adapt, and grow.
Wow. So the brain is literally starving itself of the chemicals required to feel stable and happy, while simultaneously flooding itself with toxic, excitatory chemicals that cause structural damage. I mean, no wonder there are psychiatric manifestations. What does this actually look like in the clinic? If I'm a doctor walking onto a COVID ward, what am I seeing?
In the acute phase, especially for patients hospitalized with severe COVID-19, the extrapulmonary complications are striking. Delirium is incredibly common. We see it in roughly 55% of hospitalized patients.
55%.
Yeah.
That is huge.
It is. Delirium is an acute fluctuating state of confusion, characterized by inattention, disorientation, and altered levels of consciousness. The patient might be hallucinating, deeply agitated, or conversely, profoundly lethargic. It is a direct clinical manifestation of that toxic biochemical storm ravaging the cortex.
Over half of hospitalized patients experiencing severe delirium. That is a massive burden on the healthcare system and the nursing staff. But the story doesn't end when they are discharged, does it? What about the post-acute phase? Long COVID seems to be a really significant psychiatric challenge.
Post-acute sequelae of COVID, or PSYCH, commonly known as long COVID, presents a really complex clinical picture. The symptoms can last for months or even years, ranging from a mild annoyance to entirely debilitating. Patients report profound fatigue, dyspnoea, and what they describe as brain fog.
Right, the brain fog.
Which manifests objectively as measurable cognitive impairment. We're talking poor concentration, working memory deficits, and executive dysfunction. Psychiatrically, anxiety, depression, and significant sleep impairments are highly prevalent.
If you're listening to this and wondering who is most at risk for this long-haul syndrome, what do the data actually tell us?
Large observational studies suggest the risk factors for developing long COVID include increasing age, a high body mass index, female sex, and crucially, the initial severity of the viral attack.
So how sick you were in week 1?
Precisely. Having more than 5 distinct symptoms during the very first week of the illness is a strong predictor for prolonged post-acute sequelae.
The reading highlights something fascinating about the relationship between COVID and psychiatric illness, too.
Yeah.
It isn't just a one-way street where the virus causes mental health issues. It's actually a bidirectional relationship.
That is a critical point for clinical reasoning. Having a pre-existing mental disorder, especially severe conditions like major depressive disorder or schizophrenia, actually elevated a person's risk of catching COVID-19 in the first place.
Wow, really?
Yes. Furthermore, once infected, these patients faced significantly increased rates of mortality and hospitalization compared to the general population. This speaks to the systemic biological vulnerabilities, immune dysregulation, and social determinants of health often associated with severe mental illness.
And on the flip side, simply surviving COVID carries its own delayed psychiatric risk.
A large-scale retrospective cohort study showed that recovering patients have a 5.8% probability of being newly diagnosed with a psychiatric illness within 14 to 90 days post-diagnosis.
These are patients with 0 prior psychiatric history.
Exactly, no prior history. The most frequent diagnoses are anxiety disorders and trauma-related conditions, such as adjustment disorder, generalized anxiety disorder, and PTSD. So the virus exacerbates underlying psychiatric vulnerability, and pre-existing psychiatric vulnerability exacerbates the viral impact. It is a vicious cycle.
So, bringing this to the clinical meaning for the practitioner, we have a virus causing global inflammation, altering brain chemistry via the cognition pathway, and leaving a wake of acute delirium and long-term psychiatric symptoms. How does this complicate treatment, particularly in the intensive care unit?
Well, this brings us to a really sobering reality of critical care psychiatry, the risk of opportunistic infections. Severe COVID-19 frequently leads to acute respiratory distress syndrome, or ARDS. The lungs fill with fluid and oxygen exchange just fails.
And the life-saving, evidence-based treatment for this involves mechanical ventilation, right?
Yes, ventilation, high-dose systemic corticosteroids like dexamethasone, and broad-spectrum antibiotics.
The steroids are used to suppress the cytokine storm, basically telling the immune system to stand down before it destroys the lungs completely.
That's the intent. You're trying to save the patient's life from acute respiratory failure. However, SARS-CoV-2 already intrinsically impairs cell-mediated immunity by decreasing CD4+ and CD8+ T-cell counts.
So the virus weakens the immune system, and then the doctors have to weaken it even further with steroids.
Exactly. When you take a patient whose immune system is already battered by the virus, and you intentionally suppress it further with high-dose steroids, you create an incredibly vulnerable host. If that patient also has underlying comorbidities, like poorly controlled diabetes mellitus, for instance, you have engineered the perfect environment for an opportunistic nightmare to take hold.
And in the context of COVID-19, that nightmare was often mucormycosis.
Yes, mucormycosis.
I remember reading terrifying headlines about the black fungus outbreaks during the pandemic, especially in places like India.
It was horrific. Mucormycosis is caused by fungi of the order Mucorales. Now, these are ubiquitous environmental fungi found in soil, decaying matter, and everyday dust. A healthy immune system clears inhaled spores effortlessly.
We breathe them in all the time.
All the time. But in a highly immunocompromised diabetic patient on high-dose steroids, these spores germinate into invasive hyphae. These fungal filaments aggressively invade the blood vessels, causing thrombosis blood clots, which cuts off the blood supply.
Which kills the tissue.
Exactly. It leads to tissue infarction and massive, rapid necrosis of the surrounding flesh.
How does an environmental fungus in the nose manage to breach the brain, though?
The initial clinical manifestation might seem innocuous at first. A slight fever, unilateral facial pain, nasal congestion with a purulent discharge, and a headache. But this fungus does not respect anatomical boundaries. It spreads contiguously, literally eating through tissue. If it's not caught aggressively early, it invades right through the cribriform plate.
That's the porous, spongy bone at the roof of the nasal cavity, right? Where the olfactory nerves are.
Yes. Once it breaches the cribriform plate, it moves directly into the orbit of the eye and the frontal lobes of the brain. This condition, rhinoorbital cerebral mucormycosis, has a mortality rate exceeding 50%.
50%. That's devastating.
And that's even with immediate intravenous antifungal treatment and extensive surgical debridement to cut away the dead tissue.
If you're the attending physician, you're trapped in this terrible bind. The high-dose steroids you absolutely must use to save the patient from dying of ARDS today are the exact same drugs that open the door for a flesh-eating fungus to invade their brain next week. Or, less lethally but still severely, those steroids can induce a substance-induced manic or psychotic episode themselves. How does a doctor navigate that?
It highlights the incredibly delicate risk-benefit analysis required in medicine. You are constantly weighing the immediate acute threat of respiratory failure against the severe, delayed risks of profound immunosuppression and neuropsychiatric fallout. It is a high-wire act, and it requires constant vigilance.
So you treat the ARDS, but you watch them like a hawk.
You monitor their blood glucose meticulously, you inspect their nasal passages daily, and you watch closely for any sudden changes in mental status.
That perfectly illustrates the chaos of a systemic infection. From a virus that causes widespread collateral damage, we need to transition now to pathogens that act less like an invading army and more like, precision snipers.
The direct invaders.
Right. These invaders target very specific, anatomically distinct regions of the brain. Let's look at the viral encephalitis.
Encephalitis literally means inflammation of the brain parenchyma itself. And the quintessential example here, the one every clinician must know, is herpes simplex virus encephalitis, or HSVE, specifically HSV1, which is the most commonly identified cause of sporadic acute viral encephalitis globally.
I think the average person hears herpes simplex virus 1 and immediately thinks of just a standard cold sore on the lip. How does a virus responsible for cold sores end up melting down the human brain?
The pathogenesis is remarkable, and it really speaks to how viruses adapt to their hosts over millennia. In about 30% of HSVE cases, it's a primary infection, so the patient's first exposure to the virus. But in roughly 70% of cases, it is actually a reactivation of a latent infection.
So they've had it for years.
Yes. After an initial oral infection, the virus travels up the sensory nerves and integrates its DNA into the host cell genome within the trigeminal ganglion. It lies dormant there for years, completely evading the immune system.
And then something wakes it up.
Exactly. When it reactivates due to stress, immunosuppression, or often unknown triggers, it doesn't just travel back down to the lip to cause a cold sore. It travels via the olfactory nerve or the trigeminal nerve directly into the cranial vault.
It essentially uses our own sensory wiring as a private, high-speed tunnel straight past the blood-brain barrier.
It does. And because of that specific entry route via the base of the skull, the virus has a striking predilection for very specific neural structures. It aggressively targets the temporal lobes, the hippocampus, the insula, and the orbitofrontal cortex.
And it doesn't just inflame them.
No. Furthermore, HSV1 has evolved a devastating mechanism to evade the host's cellular defenses. It actively inhibits a process called autophagy.
Autophagy, that's the cell's way of cleaning itself out.
Right. It's normally the cell's internal garbage disposal system. It clears out damaged components and intracellular pathogens. By turning off the garbage disposal, the virus replicates unchecked. This leads to massive tissue edema, profound inflammation, and ultimately hemorrhagic necrosis in those specific brain regions.
Hemorrhagic necrosis. So it is essentially causing the temporal and frontal lobes to bleed and die. If we move to the manifestation, what does that actually look like in a patient? I imagine it doesn't look like a typical flu.
It often begins deceptively. There's a seemingly benign prodrome, a mild fever, a headache, maybe some lethargy. But within a few days, this is rapidly followed by an abrupt, massive change in personality and behavior.
Abrupt being the key word.
Very abrupt. The patient will exhibit profound alterations in consciousness, ranging from confusion to coma, and frequently focal or generalized seizures.
If it's destroying the temporal lobes and the orbitofrontal cortex, it's like the virus specifically targets the brain's emotional control room and its memory banks simultaneously.
That is a highly accurate way to visualize it. Because those regions govern emotion, impulse control, and memory formation, the psychiatric symptoms are profound and often the most prominent feature early on. We can categorize these manifestations into four main areas, though they frequently overlap in a single patient.
Okay, what's the first one?
First, psychosis. This can include bizarre delusional thinking and hallucinations across all sensory modalities. And we're not just talking auditory hallucinations. We see visual, olfactory, and gustatory hallucinations, which strongly suggest a temporal lobe lesion.
Because the temporal lobe processes smell and taste.
Precisely. Second, severe catatonia. Third, profound depression with psychotic features. And fourth, acute mania, presenting with extreme irritability, unpredictable aggression, hypersexuality, and complete social disinhibition.
You mentioned the hippocampus is targeted. The memory loss must be absolute.
The amnesic syndrome is devastating. Patients experience profound anterograde amnesia, meaning they lose the ability to form any new memories. Their retrograde memories from before the infection might be partially preserved, but they are essentially trapped in the present moment.
Wow. And what if they survive?
Long-term, even if they survive the acute viral attack, the structural damage leaves severe, permanent sequelae. A classic consequence is Cleaver-Bucy syndrome.
I remember learning about Cleaver-Bucy in med school.
It occurs following bilateral temporal lobe destruction. It's characterized by hyperorality, which is the compulsion to put objects in the mouth to explore them, hypersexuality, visual agnosia, which is the inability to recognize familiar objects, and a striking emotional placidity. Apathy, persistent irritability, and devastating cognitive deficits are very common in survivors.
So imagine you're a psychiatrist on call in the A&E. A patient is brought in by their family. They're acting erratically, hallucinating vividly, perhaps making inappropriate sexual advances, and they have absolutely no idea what year it is. How do you distinguish this from a primary psychiatric break, like new onset schizophrenia or severe bipolar mania? What is the clinical meaning here?
This brings us to an absolute golden rule for clinicians, a cornerstone of psychiatric medical clearance. A history of fever, paired with sudden psychiatric changes, confusion, or any focal neurologic signs, means you must suspect HSVE and you must treat it immediately.
So you don't assume it's functional?
You cannot assume it is a functional psychiatric illness.
So you don't wait for the lab results to come back confirming the virus?
You absolutely do not wait. You perform a lumbar puncture to analyze the cerebrospinal fluid. The typical CSF profile for viral encephalitis will show a lymphocyte-predominant pleocytosis, meaning an elevated white blood cell count driven by lymphocytes. It will show elevated protein levels due to the inflammation, and crucially, a normal glucose level.
Because bacteria eat glucose, but viruses don't.
Exactly, which helps differentiate it from bacterial meningitis. You will order a PCR test on the CSF for HSV1 DNA and an MRI of the brain, which might eventually show unilateral or bilateral temporal lobe edema or hemorrhage. But you do not wait for the PCR or the MRI to confirm the diagnosis before acting.
To treat empirically.
Yes. Suspected HSVE requires immediate administration of intravenous acyclovir for a course of 14 to 21 days. Delaying treatment by even a few hours dramatically increases the risk of permanent brain damage and death.
While the acyclovir fights the virus, how do you manage the acute psychiatric fallout? I mean, if the patient is violently manic, terrified by hallucinations, or highly aggressive, you still have to keep them and the staff safe. Do you just use standard psychiatric drugs?
You have to proceed with extreme vigilant caution. Managing severe agitation or psychosis in a brain that is actively undergoing hemorrhagic necrosis is fraught with danger. If you administer standard high-potency antipsychotics like haloperidol, these patients have a significantly increased risk of developing neuroleptic malignant syndrome, or NMS.
NMS is terrifying.
It is a potentially fatal idiosyncratic reaction to dopamine antagonists, characterized by severe muscle rigidity, hyperthermia, and autonomic instability. The inflamed, damaged brain state is simply too vulnerable to tolerate aggressive neuroleptic blockade. Dosing must be incredibly conservative, often relying more on benzodiazepines or low-dose atypical antipsychotics, with constant monitoring of their neurologic status.
HSV uses our own internal nervous system to sneak into the brain. But other viruses don't have that internal latent access, do they? They need a delivery mechanism. They need a courier to get past the outer walls of the body. Let's move to segment 3, the vector-borne viruses. We're talking about mosquitoes, ticks, and the animal kingdom acting as the delivery system.
This is a diverse and highly consequential group of pathogens, often referred to as arboviruses, arthropod-borne viruses. We can broadly divide them by their viral families to understand their clinical impact. Let's start with the alpha viruses, which include several pathogens that cause severe encephalitic disease, particularly in the Americas.
Chikungunya is an alpha virus that has been making global headlines over the last decade. It's spread by the Aedes mosquito. We usually hear about it causing terrible joint pain, but what is the neuropsychiatric angle there?
While chikungunya is indeed famous for causing severe, debilitating rheumatoid-like arthralgia, its neurologic complications are devastating, particularly in the context of vertical transmission.
Meaning mother to baby.
Yes. If a mother is acutely infected with chikungunya during the perinatal period, right around delivery, there is a staggering 50% transmission rate to the neonate. Importantly, this transmission rate holds regardless of whether it is a vaginal delivery or a cesarean section. The virus crosses over, and symptomatic newborns can develop severe acute meningoencephalitis.
The neonatal brain is still wiring itself. What does massive viral inflammation do to a brain at that stage of development?
The long-term effects are incredibly grim. Survivors of symptomatic neonatal chikungunya infections have exceedingly high rates of severe neurodevelopmental delays. It fundamentally disrupts cognitive functioning, leading to persistent neurologic sequelae like intractable epilepsy, severe language impairment, and motor deficits.
Staying with the alpha viruses, we have the equine encephalitids. Western equine encephalitis, or WEE, is spread by the Culex mosquito.
WEE is thankfully rare now due to agricultural changes in vector control, but it is worth noting because of how it presents. In severe cases, patients quickly progress from fever to a comatose state. What is clinically relevant here is that the duration of the coma directly predicts the severity of the long-term neurologic and cognitive sequelae.
So the longer they are under, the worse the outcome.
The longer the brain is suppressed by the inflammation, the worse the outcome, especially in infants who are disproportionately hit the hardest by WE.
And then there's its eastern counterpart, Eastern equine encephalitis, or EE.
EE is a terrifying pathogen. It is the deadliest arbovirus endemic to the United States. It carries a mortality rate of roughly 30%. The clinical manifestation is a rapid, brutal deterioration. Patients present with high-grade fever, severe delirium, and seizures. The vast majority of symptomatic patients will slip into a coma within 2 days of hospitalization.
If a patient comes in with this rapid, unexplained encephalopathic decline, and you suspect an arbovirus, is there a way to spot EE on a brain scan?
Yes, there is. If we connect this to the bigger picture of neuroimaging, there is a classic radiologic sign to look for. EE mainly affects the basal ganglia and the thalamus, the deep brain structures. On an MRI, specifically on T2 or FLAIR sequences, you might see what neuroradiologists call the parenthesis sign.
The parenthesis sign, what does that look like?
These are distinct linear hyperintensities located in the external and internal capsules. Crucially, they spare the lentiform nuclei in the middle. Because of the anatomy of those structures, the bright white lesions literally look like a pair of parentheses bracketing the deep gray matter.
That's a great visual anchor for the listener.
Yeah.
Moving from the alpha viruses to the flaviviruses. Dengue fever is a massive global health burden. We're talking somewhere between 100 to 400 million infections a year.
Dengue, which is also spread by the Aedes mosquito, presents a fascinating and dangerous immunologic paradox. There are 4 different serotypes of the dengue virus. If you are infected with one serotype, say serotype 1, your immune system clears it, and you develop robust, lifelong immunity to that specific strain.
That sounds like standard immunology. You get sick, you build antibodies, you're protected.
It is standard until you get bitten by a mosquito carrying a different serotype, say serotype 2. The antibodies from the first infection recognize the new virus, but they aren't perfectly matched. They provide partial, temporary cross-immunity, but they actually fail to neutralize the new virus.
So what do?
Instead, they bind to it and facilitate its entry into the host's macrophages. This is called antibody-dependent enhancement. It primes the immune system to violently overreact. This second infection often leads to severe dengue, characterized by massive plasma leakage out of the blood vessels, hypovolemic shock, and disseminated intravascular coagulopathy, where the blood simultaneously clots and bleeds everywhere.
So your own immune system's memory of the first infection is weaponized to make the second infection deadly. What about the psychiatric manifestations of that kind of systemic shock?
Beyond the sheer trauma of surviving a life-threatening illness in an ICU, case reports heavily document post-infection psychiatric states. We frequently see post-infection mania and acute onset psychosis. This is likely driven not by direct viral invasion of the brain, but by the massive, overwhelming cytokine storm and the hypoxic damage caused by the hypovolemic shock.
Staying with the flaviviruses, what about Powassan virus? I know this one is driven by hard ticks, the Ixodes ticks, and it's linked to white-tailed deer populations.
Yes, and its incidence has been rising steadily in the United States, particularly in the Northeast and Great Lakes regions, over the last 2 decades as tick habitats expand. Powassan causes a severe encephalitis that is frequently complicated by seizures and paralysis. It has a 10% mortality rate, and of those who survive the severe neuroinvasive form, about half are left with significant permanent long-term neurologic disability, including hemiplegia and severe cognitive deficits.
And West Nile virus. That is the one that usually makes the evening news every summer.
West Nile virus relies on migratory birds as its primary reservoir and Culex mosquitoes as the vector bridging it to humans. Now, it is important to note that most human infections, about 80%, are completely asymptomatic. Another 20% develop a self-limiting febrile illness.
So it's a very small percentage that gets severe neurosymptoms.
Right. Neuroinvasive disease occurs in less than 1% of patients. But when it does invade the central nervous system, it classically presents in one of 3 distinct ways. First, as a meningitis, presenting with a stiff neck, severe headache, and photophobia. Second, as an encephalitis with profound lethargy, confusion, and personality changes. And third, as acute flaccid paralysis.
What does acute flaccid paralysis look like clinically, and how does the virus cause it?
The virus specifically targets and destroys the anterior horn cells in the spinal cord, which are the motor neurons responsible for voluntary muscle movement. Clinically, it presents as an abrupt onset of asymmetric limb weakness that progresses very rapidly, often over just 48 hours.
Just sudden weakness.
Yes, and the affected limbs are hyperreflexic or areflexic, meaning the deep tendon reflexes are completely absent. Crucially, there are no sensory abnormalities. The sensory tracts in the spinal cord are spared, so the patient can feel everything perfectly: pain, touch, temperature, but they suddenly, terrifyingly, cannot move the limb.
That is horrific. And speaking of horrific, that brings us to perhaps the most infamous vector-borne virus of all, belonging to the Rhabdoviridae family, rabies.
Rabies is the ultimate accidental hitchhiker. Globally, it remains a massive public health issue, responsible for around 60,000 deaths a year, primarily transmitted through dog bites in areas lacking robust vaccination programs. In the United States and Europe, human exposure is more commonly linked to wildlife reservoirs like raccoons, skunks, and, crucially, bats.
You mentioned retrograde axonal transport earlier with COVID as a potential entry route. Is that exactly what rabies does?
Precisely, but rabies executes it with terrifying efficiency. When an infected animal bites a human, the virus is deposited deep into the muscle tissue. It multiplies locally inside the myocytes at the site of the bite. Then it binds to the nicotinic acetylcholine receptors at the neuromuscular junction.
So it enters the nerves right there.
It enters the motor and sensory axons and then travels retrogradely backwards up the long nerve fibers at a rate of a few centimeters a day towards the central nervous system.
A few centimeters a day, so if you get bitten on the foot, it could take months.
Exactly. During this transit, the patient feels fine. There are no symptoms. Once it reaches the spinal cord and brain, it disseminates rapidly, causing severe encephalitis, before spreading interogradally back out along the autonomic nerves to other organs, including concentrating heavily in the salivary glands. By the time the first clinical symptoms appear, the virus is already everywhere in the CNS, and the disease is almost universally fatal.
The symptoms are legendary in medical history. There are 2 distinct forms, right?
Yes. About 20% of cases present as paralytic rabies, which clinically resembles Guillain-Barré syndrome with a progressive ascending paralysis. But the more common form, accounting for 80% of cases, is furious rabies.
Furious rabies.
Furious rabies initially presents psychiatrically with intense anxiety, agitation, or acute psychosis. Patients develop a profoundly fluctuating consciousness, wildly alternating between periods of severe manic agitation and periods of lucid depression. They experience severe autonomic dysfunction, aggressive biting behavior, and most famously, hydrophobia and aerophobia.
Wait, let's explore hydrophobia. Why a fear of water? What possible advantage does a virus gain from making its mammalian host terrified of water?
It is a breathtakingly dark, brilliant evolutionary adaptation. The hydrophobia isn't an irrational psychological fear of water itself. It manifests as severe, excruciatingly painful phobic spasms of the throat and inspiratory muscles whenever the patient attempts to drink, or even sees or hears water pouring.
So they physically can't swallow without agony.
Right. Now, consider the viral objective. The virus has concentrated itself in the host's salivary glands. By preventing the host from drinking or swallowing, the virus ensures that the virus-laden saliva is not washed down into the stomach where stomach acid would destroy it. The mouth remains filled to the brim with highly infectious saliva.
Oh my God.
Paired with the virus-induced aggression, confusion, and biting behavior, this mechanism absolutely maximizes the chances of transmission into the flesh of a new host before the current host dies.
The virus literally manipulates the brain's motor output and psychological state to weaponize the host's own saliva. That is chilling. So we've seen how viruses mutate, hijack cellular machinery, and manipulate behavior. But viruses aren't the only shapeshifters out there causing psychiatric chaos. Let's transition from the viral world to the bacterial world. Segment 4, the great imitators. We're looking at spirochetes and the slow, insidious burn of bacterial neuroinvasion.
The term great imitator belongs historically and rightfully to syphilis. It is caused by the spirochete bacterium Treponema pallidum. The reason it holds this title is because its clinical manifestations are so varied and span such a long time frame that it can masquerade as dozens of different medical and psychiatric conditions.
Walk us through the timeline of this slow burn. If someone is infected, what happens over the ensuing months and years?
It is a disease defined by distinct clinical stages. Primary syphilis occurs 10 days to 3 months after the initial infection, presenting simply as a painless ulcer called a chunker at the mucosal entry site. Because it's painless, it is often ignored.
They might not even know it's there.
Exactly. Without treatment, the spirochetes disseminate through the bloodstream, and within a few months, the disease progresses to secondary syphilis. This is the systemic phase. Patients typically present with constitutional symptoms: fever, malaise, swollen lymph nodes, and a very characteristic maculopapular rash that notably involves the palms of the hands and the soles of the feet.
Okay, so that's the systemic phase. When does it hit the brain?
Interestingly, we know from lumbar punctures that neuroinvasion, the bacteria entering the cerebrospinal fluid, often happens during these early primary and secondary stages. But in many cases, a robust immune system manages to spontaneously clear the infection from the CNS, even if the systemic infection remains.
But if the immune system fails to clear it from the brain, what is the clinical consequence?
If the spirochetes establish a foothold in the CNS, you develop early neurosyphilis. This can manifest relatively early on as syphilitic meningitis, presenting with headaches, stiff neck, and cranial nerve palsies, often affecting the nerves controlling eye movement or hearing. Alternatively, it can present as meningovascular neurosyphilis.
Let's define meningovascular in this context. What does that mean for the patient?
The bacteria cause an intense inflammation of the inner lining of the arteries supplying the brain and spinal cord, a condition called obliterative endarteritis. The walls of the blood vessels thicken and inflame until the vessel is completely occluded. This chokes off the blood supply to the brain tissue downstream, leading to focal ischemia.
So they have a stroke?
Essentially, yes. The patient presents with a classic stroke syndrome, perhaps hemiplegia or aphasia.
So a 30-year-old presenting in the A&E with a stroke could actually be suffering from early neurosyphilis affecting their blood vessels. And what happens if the disease goes unrecognized and untreated for decades?
If the patient survives the early stages, the disease enters a latent phase. Then, 10 to 20 years after the initial infection, you enter tertiary syphilis and late neurosyphilis. This stage is characterized by severe, irreversible tissue destruction.
10 to 20 years later.
Yes. It includes the formation of gummas, which are destructive, ulcerating granulomatous lesions that can form in the brain, bones, or skin. Neurologically, it includes tabes dorsalis, which is a slow, progressive degeneration of the posterior columns of the spinal cord. Patients lose their deep tendon reflexes and their proprioception, their sense of where their limbs are in space, leading to a characteristic stamping gait.
And what about the psychiatric focus?
Most critically for our psychiatric focus, late neurosyphilis causes general paresis.
General paresis. I've heard that term in historical medical contexts. What is the clinical picture there?
General paresis, sometimes historically called general paralysis of the insane, is a chronic, progressive frontotemporal meningoencephalitis. The spirochetes have been slowly causing widespread inflammation and neuronal death in the frontal and temporal lobes for decades. It is a relentless destruction of global cortical function.
And here's where it gets incredibly important for the psychiatrists, right? Because this is precisely why it earned the title of the Great Imitator.
Exactly. Because it affects the frontal and temporal lobes globally, general paresis can mimic almost any primary psychiatric disorder in the DSM. It can present with profound treatment-resistant mood disturbances, either severe melancholic depression or striking euphoria and acute mania. It causes severe anxiety, vivid auditory and visual hallucinations, bizarre delusional thinking, often delusions of grandeur, extreme apathy, and complete social disinhibition.
So they might present exactly like someone with schizophrenia or bipolar disorder?
Yes. On neurocognitive testing, the pattern of cognitive impairment, the severe memory loss, language deficits, and spatial inability can perfectly mimic Alzheimer's disease or frontotemporal dementia. You simply cannot distinguish between primary schizophrenia, severe bipolar disorder, Alzheimer's dementia, and general paresis based on clinical observation alone.
That makes diagnosis incredibly fraught. If you see a patient with new onset mania age 55, you have to consider a bacterial infection they caught when they were 30. You mentioned another spirochete earlier, Borrelia burgdorferi, which causes Lyme disease.
Yes. Lyme disease is transmitted by the bite of an infected Ixodes tick, the same vector family we discussed with Powassan virus. Early Lyme disease is quite famous for the erythema chronicum migrans, the expanding bullseye rash at the site of the tick bite. Early neurologic symptoms can include facial nerve palsy, like Bell's palsy, and a mild lymphocytic meningitis.
But similar to syphilis, it is the late-stage disseminated disease where the psychiatric symptoms start to creep in.
Correct. If left untreated, months or years later, late neurologic Lyme can present as a subacute mild encephalopathy. The bacteria cause mild inflammation that affects cognitive domains, particularly short-term memory, processing speed, and concentration. Psychiatrically, we see severe irritability, mood lability, dysthymia, and clinical depression.
And the depression can be severe, right?
The stakes here are very high for the patient's well-being. A massive comprehensive registry study utilizing data from Denmark and the United States showed that patients with a verified diagnosis of Lyme disease had a 42% higher rate of affective disorders, like major depression and bipolar disorder. More alarmingly, they had a staggering 75% higher rate of death by suicide compared to demographically matched individuals without a Lyme diagnosis.
A 75% higher suicide rate. That is a massive clinical red flag. It speaks to the profound suffering caused by the neuroinflammation. Now, I know there's a lot of clinical controversy and public debate surrounding Lyme disease, particularly regarding patients who remain symptomatic after treatment. Can you clarify the medical terminology and the differing viewpoints there?
It is vital to use precise, evidence-based language here, as the terminology is often conflated in the public sphere. There is post-treatment Lyme syndrome, and there is chronic Lyme disease.
Let's start with post-treatment Lyme syndrome.
Post-treatment Lyme syndrome refers to a specific cohort of patients who had a verified, objectively defined prior Lyme infection, so positive serology, classic rash, who receives the standard evidence-based course of antibiotic treatment, but who continue to experience persistent, often debilitating symptoms for months afterwards.
Symptoms like what?
These symptoms typically include severe fatigue, sleep disorders, subjective memory difficulties, and widespread joint pain. The prevailing scientific theory is that this might represent an immune echo. The bacteria have been eradicated by the antibiotics, but the initial infection triggered an ongoing post-infectious secondary immune response, a lingering autoimmune or inflammatory state.
And how does that differ from the term chronic Lyme?
Chronic Lyme disease is a highly heterogeneous catch-all term often used outside mainstream infectious disease guidelines. It frequently includes people who fit the post-treatment syndrome criteria, but it is also broadly applied to patients experiencing nonspecific chronic illnesses like severe fatigue or widespread pain who actually lack any objective clinical or serologic evidence of ever having had a primary Borrelia infection.
So they might have never had Lyme at all.
Right. Mainstream medicine maintains that prolonged courses of intravenous antibiotics for chronic Lyme are not evidence-based and carry significant risks, whereas treating the residual symptoms of post-treatment Lyme syndrome is focused on rehabilitation and managing that immune echo.
So bringing it back to the clinician facing these great imitators, if general paresis looks like Alzheimer's and late Lyme looks like depression, what does this mean for diagnosis?
It means diagnosis requires an incredibly high index of suspicion and routine screening. For syphilis, because it can mimic anything, you must order serologic testing for atypical psychiatric presentations. You start with a non-treponemal test like the VDRL or RPR to look for general inflammation, and if positive, it must be confirmed by a highly specific treponemal test like the FTA-ABS, which detects antibodies specifically against Treponema pallidum.
And what if you scan their brain?
If you perform an MRI on a patient with general paresis, you will typically see marked frontocortical atrophy. The brain tissue in the frontal lobes has physically shrunk due to decades of neuronal death.
And the treatment for a disease that has been eating away at the brain for 20 years.
Despite the incredible complexity and devastation of the disease, the treatment for syphilis remains remarkably straightforward: penicillin G. The spirit has never developed widespread resistance to it. However, the critical caveat is that penicillin will only kill the bacteria and halt the progression. Reversing the psychiatric and cognitive symptoms depends entirely on catching it before irreversible neuronal death has occurred. Once the cortex has atrophied, the dementia is permanent.
We just touched on the concept of an immune echo in post-treatment Lyme syndrome. Let's transition to segment 5, where we look at what happens when that immune echo doesn't just cause generalized fatigue, but actively targets and attacks the brain's specific movement and behavior centers. These are the autoimmune echoes, when the citadel essentially turns its weapons on itself.
Our clinical focus here shifts to group A beta hemolytic streptococcus, or GABHS. This is the extremely common bacteria responsible for standard strep throat or impetigo in children.
It is wild to think that a simple, everyday childhood throat infection can trigger a full-blown psychiatric emergency. How does a sore throat cause an autoimmune brain attack?
It is a fascinating and tragic cascade known as molecular mimicry. The GABHS bacteria infect the upper respiratory tract. The child's immune system detects the invader and appropriately generates antibodies designed to seek out and destroy the streptococcus proteins. However, due to a specific, likely genetic vulnerability in certain children, these autoantibodies are slightly imprecise.
Imprecise how?
They don't just attack the bacterial proteins, they mistakenly cross-react with epitope-specific protein sequences that are naturally located in the basal ganglia of the child's own brain. The antibodies mistake the brain tissue for the strep bacteria.
It is microscopic friendly fire.
Precisely. To build our mental model, the basal ganglia are deep brain structures that act as crucial regulatory nodes in the cortical basal ganglia thalamocortical circuits, or the CBGTC circuits.
And what do those circuits do?
These neural loops govern motor control, habit formation, behavior, and cognitive gating, filtering out unwanted thoughts or movements. When the rogue autoantibodies cross the blood-brain barrier and bind to these structures, the CBGTC circuits become inflamed and severely disrupted. This disruption leads to explosive, uncontrollable neuropsychiatric symptoms.
And the textbook details two main manifestations of this streptococcal autoimmune reaction: Sydenham chorea and pandas. Let's start with Sydenham chorea.
Sydenham chorea is the classic, historically recognized neurologic manifestation of acute rheumatic fever. It usually occurs weeks to months after the initial strep infection. It is characterized by chorea. Chorea refers to irregular, semi-purposeful, avolitional, adventitious movements.
So they can't control their body.
Right. The child might seem like they're constantly fidgeting, grimacing, or engaging in a bizarre, jerky dance, but the movements are completely involuntary and cause severe functional impairment.
And then we have PANDAS, pediatric autoimmune neuropsychiatric disorders associated with streptococcus.
PANDAS is where the psychiatric presentation takes center stage. The clinical presentation is incredibly striking because of its abruptness. It is often described as an overnight onset. A caregiver will bring their child into the clinic in absolute distress and say, "Doctor, my child went to bed perfectly fine on Tuesday, and they woke up on Wednesday completely new, terrified, and unrecognizable."
What are these specific symptoms that manifest overnight?
The core features are sudden, severe obsessive-compulsive disorder, or OCD, and the sudden onset of vocal or motor tics. A child who has never shown anxiety might suddenly be washing their hands until they bleed or performing elaborate, terrifying rituals.
Just out of nowhere.
Yes. But it's not just OCD. It is accompanied by profound global behavioral regression. We see severe separation anxiety, night terrors, emotional lability, and an abrupt deterioration in fine motor skills, which often shows up as dramatically worsened handwriting at school. Interestingly, there's frequently sudden urinary urgency or frequency, which is often misdiagnosed initially as a simple urinary tract infection before the full psychiatric picture becomes clear.
In recent literature, you also hear the term PANS used alongside PANDAS. How is PANS different?
PANS stands for Pediatric Acute Onset Neuropsychiatric Syndrome. It's the broader, more encompassing diagnostic category. It describes the exact same sudden dramatic onset of severe OCD or severely restricted food intake, an acute eating disorder accompanied by the same cognitive decline, habits, and emotional ability.
So what's the difference?
The difference lies purely in the trigger. While PANDAS is strictly defined as being triggered by GABHS, PANS acknowledges that this identical clinical syndrome can be triggered by other infections. Pathogens such as Mycoplasma pneumonia, the influenza virus, or even Lyme disease can trigger the exact same autoimmune attack on the basal ganglia. The resulting psychiatric presentation is the same. The inciting infectious agent is just more diverse.
So putting ourselves in the shoes of the clinician, a frantic parent brings in a 7-year-old whose personality changed overnight following a mild fever last week. How do you objectively pin this down and differentiate it from standard new-onset childhood OCD?
You rely on strict, established clinical criteria. For PANDAS, there are 5 specific criteria that must be met. 1, the presence of clinically significant OCD or a dentic disorder. 2, prepubertal onset. This is a childhood disorder. 3, an exceptionally abrupt onset and an episodic relapsing remitting course. The symptoms flare wildly with subsequent infections.
And the 4th?
4, the presence of neurologic abnormalities, such as coriform movements, mild chorea, or extreme hyperactivity during the exacerbations. And 5, a clear, documented temporal relationship between the JBHS infection proven by a throat swab or rising strep antibody titers and the onset or exacerbation of symptoms.
And the treatment. How do you treat a severe psychiatric disorder like OCD when you know it is actually an autoimmune reaction to a bacteria?
It requires a highly coordinated multimodal approach bridging psychiatry, immunology, and infectious disease. You use standard psychiatric treatments to alleviate the immediate suffering. Cognitive behavioral therapy and SSRIs are deployed to help the child manage the severe OCD and anxiety symptoms. But unlike standard OCD, you must also address the underlying etiology.
You have to clear the infection.
Right. Antibiotics like penicillin, amoxicillin, or cephalosporins are prescribed to eradicate any residual streptococcal infection lurking in the tonsils. And in severe refractory cases where the brain inflammation is causing profound impairment, aggressive immunomodulatory treatments are deployed. This includes intravenous immunoglobulin, or IVIG, to neutralize the rogue antibodies, or plasmapheresis, which literally filters the child's blood to physically remove the cross-reacting autoantibodies from circulation.
It is incredible. We've seen viruses melt the temporal lobe in HSV, we've seen bacteria imitate Alzheimer's in syphilis, and we've seen the immune system attack the basal ganglia in pandas. Now we enter the realm of the parasites. Let's move to segment 6, the parasitic hijackers and the microscopic assassins. Let's start with a crowd favorite, Toxoplasma gondii.
Toxoplasmosis is undeniably one of the most successful parasitic infections globally. Seroprevalence studies indicate it currently infects roughly 1/3 of the entire human population.
1/3 of everyone on Earth.
Yes. It is an obligate intracellular protozoan, meaning it must live inside the cells of its host to survive.
And the domestic cat is the main villain in this parasitic story, right?
The feline family, including domestic cats, are the definitive hosts for T. gondii. They are the only animals in which the parasite can sexually reproduce. The cats excrete millions of infectious oocysts in their feces. Humans and other intermediate hosts, like rodents and livestock, usually acquire the infection through accidental ingestion.
Like from undercooked meat or cleaning a litter box.
Exactly. Eating undercooked, contaminated meat containing tissue cysts, or through poor hygiene after handling cat litter or gardening in contaminated soil. Once ingested, the parasite enters the human bloodstream and disseminates, forming durable cysts predominantly inside neurons and glial cells in the brain, as well as in muscle tissue.
Wait, I have to stop and ask about the rodent aspect of this because it is endlessly fascinating. Is it true that this parasite actually reprograms rodent brains to want to be eaten by cats?
It sounds entirely like science fiction, but yes, it is a documented biological phenomenon. When rodents are infected with T. gondii, they undergo a highly specific, targeted neurochemical alteration. The parasite actually possesses the enzyme necessary to synthesize L-dopa, a precursor to dopamine.
So it makes its own dopamine.
Yes. It elevates dopamine levels within specific regions of the rodent's brain. This neurochemical manipulation completely removes the rodent's innate evolutionary aversion to the odor of cat urine. In fact, it replaces that fear with a fatal attraction to cat pheromones. The mouse loses its fear, becomes bolder, actively seeks out areas smelling of cats, gets eaten, and the parasite successfully completes its life cycle by returning to the feline gut.
That is a diabolical evolutionary strategy. What happens when that same dopamine-synthesizing parasite forms, cysts in a human brain? We aren't part of the natural life cycle. We aren't being hunted by cats.
No, we are essentially a dead-end host for the parasite. And historically, it was thought that latent toxoplasmosis in an immunocompetent human was completely asymptomatic. However, we share very similar neurochemistry with rodents. Latent infection is increasingly linked by robust epidemiological data to subtle and sometimes profound neuropsychiatric changes.
Like what kind of changes?
Studies show that T. gondii seropositivity in humans is associated with higher likelihoods of risk-taking behavior. This shows up in data sets as higher rates of entrepreneurship and business risk, but also, significantly, as increased rates of motor vehicle accidents. The parasite may be subtly altering human risk tolerance.
Lowering our natural aversions, just like in the mouse. What about the links to severe psychiatric illness?
This is a major area of psychiatric research. There is a highly significant, well-replicated association between the presence of IgM antibodies against T. gondii, indicating recent or active infection, and the onset of acute psychosis and schizophrenia. Research indicates that specific virulent strains, like type I, can actually alter the host cell expression of genes involved in brain development, immune modulation, and synaptic plasticity.
So it's not just the dopamine is changing how the genes express themselves.
Yes. The concept of a latent parasite living in human neurons, manipulating dopamine production and altering gene expression, provides a highly compelling biological model for how an infection could lower the threshold for a psychotic illness in genetically vulnerable individuals.
From a parasite manipulating behavior, let's move to a parasite with a massive, devastating global death toll: malaria. Specifically, Plasmodium falciparum.
Malaria is transmitted by the bite of the female Anopheles mosquito. While it is primarily a systemic disease of the red blood cells, P. falciparum is unique among malaria species because it carries a high risk of causing cerebral malaria.
How does it get into the brain?
Well, the mechanism of neuroinvasion here is fundamentally vascular and inflammatory, not a direct infection of the neurons themselves. The parasitized red blood cells develop sticky knobs on their surface. These sticky cells sequester. They clump together and get physically stuck in the microvasculature, the tiny cerebral capillaries of the brain.
So they block the blood vessels.
Right. This physical blockage causes endothelial lesions in the blood-brain barrier, leading to severe cerebral edema, vascular injury, and microhemorrhages.
Choking off the microcirculation of the brain. What is the clinical manifestation of cerebral malaria?
It presents as a rapidly progressive, severe encephalopathy. Patients experience severely impaired consciousness, agitated delirium, and frequent seizures, eventually slipping into a coma. A very specific diagnostic clue for the clinician examining the patient is the presence of retinal hemorrhages, which can be seen during a fundoscopic eye exam and occur in roughly 30 to 40% of cerebral malaria cases.
And what's the prognosis if they get into a coma?
Even if treated aggressively with intravenous antimalarials like artesunate, the mortality rate remains distressingly high. And for those children who survive the coma, the hypoxic brain damage often leaves them facing permanent, severe cognitive, motor, and language deficits.
Moving from mosquito vectors to warm, freshwater environments, let's discuss amoebiasis, specifically Naegleria fowleri, often sensationalized in the media as the brain-eating amoeba.
Naegleria fowleri causes a condition called primary amoebic meningoencephalitis, or PAM. It is an exceedingly rare infection, but it is nearly always fatal. The amoeba thrives in warm freshwater lakes, rivers, and hot springs. If water containing the amoeba is forcefully inhaled up the nose, typically during swimming or diving, the organism attaches to the nasum mucosa.
And then it just travels up the nerves?
It then secretes enzymes to degrade the tissue and travels directly up the olfactory nerve bundles, crossing the cribriform plate straight into the frontal lobes of the brain.
The exact same anatomical entry route as HSV and mucormycosis.
Yes, but the tissue destruction with Naegleria is incredibly rapid and aggressive. The amoeba literally feeds on the brain tissue. It causes an acute, severe hemorrhagic meningoencephalitis. The brain swells so massively and so quickly from the intense inflammation and tissue necrosis that it causes uncal herniation.
Uncal herniation, meaning the pressure pushes the brain downward.
Yes, the increased intracranial pressure physically crushes the brainstem down through the base of the skull. Despite aggressive multi-drug therapies, death typically occurs within 7 to 10 days of the initial exposure.
Let's finish the parasite section with the helminth, a worm. Neuropsychiatric, caused by the pork tapeworm Taniasolium.
This is a major global health issue, particularly in Latin America, sub-Saharan Africa, and parts of Asia. It is, in fact, the leading infectious cause of adult-onset epilepsy in the developing world.
How does a pork tapeworm end up forming cysts inside a human brain?
It is crucial to understand the transmission route. Humans get the intestinal tapeworm by eating undercooked, infected pork. But neurocysticercosis is acquired differently. It is acquired via the fecal-oral route from close contact with a human who is already a carrier of the adult intestinal tapeworm.
So you get it from another person, not from the pork directly.
Exactly. The human carrier sheds thousands of microscopic eggs in their feces. If another person ingests those eggs due to poor sanitation or contaminated food prepared by the carrier, the eggs hatch in their stomach. The larvae penetrate the intestinal wall, enter the bloodstream, and disseminate throughout the body. When they reach the brain, they lodge in the tissue, typically at the junction between the gray matter and the white matter, and form calcified, fluid-filled cysts.
And these cysts just sit there in the brain tissue causing seizures.
Here is the fascinating and highly consequential clinical paradox of neurocysticercosis. The cysts can actually sit quietly in the brain for years or even decades, actively suppressing the local immune response to avoid detection.
So they hide.
Yes. The seizures often peak not when the worm is thriving, but when the parasite naturally begins to die. As the cyst degrades and the cyst wall loses integrity, it releases massive amounts of foreign parasitic antigens into the surrounding brain tissue. The host's immune system finally detects it and mounts a massive, aggressive inflammatory attack to clear the dead tissue.
So it's the inflammation that causes the seizures.
Yes, this intense, localized inflammation around the dying cysts, termed cysticercotic encephalitis, is what irritates the cortex and triggers the severe epileptic seizures.
So it is the host's own immune response to the dying parasite that actually causes the clinical crisis.
Exactly. And this paradox directly dictates the medical treatment strategy. If a patient comes in with seizures and an MRI reveals multiple cysts and you simply give them strong antiparasitic drugs like albendazole or praziquantel to kill the worms, you will acutely and disastrously worsen the brain inflammation.
Because you kill them all at once.
Right. By killing all the parasites simultaneously, you cause them to release all their antigens at once, triggering massive cerebral edema that can be fatal. Therefore, the standard of care requires that you must first use high-dose corticosteroids, like dexamethasone, to strictly control and dampen the host immune response before and during the administration of the anthelmintic drugs. You have to quiet the immune system down before you kill the invaders.
We've covered rapid, brutal viral attacks, slow-burning bacterial imitators, and shape-shifting parasites. Let's move to our final conceptual segment, segment 7. The slow assassins and developmental disruptors. These are infections that alter the trajectory of a life, sometimes before that life has even really begun in the womb.
We must start this section with measles and a devastating delayed complication called SSPE, subacute sclerosing panencephalitis.
I think measles is often dismissed by the public as just a standard unpleasant childhood rash.
Which is a profoundly dangerous misconception. While most children recover fully, in a rare percentage of cases, roughly 1 in 10,000, the virus is not completely cleared. A mutated form of the measles virus persists silently within the central nervous system.
For how long?
Up to a decade. Up to a decade after a perfectly normal recovered childhood measles infection, this persistent virus begins to slowly spread across the brain. It causes progressive, insidious behavioral changes, declining school performance, seizures, severe myoclonus muscle jerks, and ultimately a relentless, fatal dementia.
Is there a treatment for it?
There is currently no cure for SSPE. It is a stark, tragic reminder of the profound neuropsychiatric value of the MMR vaccine. Prevention is literally the only defense we have against this slow assassin.
And what about infections that happen before birth? The textbook outlines the maternal immune activation model.
The maternal immune activation, or MIA model, is a critical, evolving area of psychiatric and neurodevelopmental research. The core concept is that a severe maternal infection during pregnancy triggers massive inflammatory cytokine cascades in the mother's body. These inflammatory markers cross the placenta and enter the fetal circulation, directly altering fetal brain development.
So the pathogen itself doesn't even have to infect the baby.
Right, the pathogen itself doesn't necessarily need to infect the fetal brain, but the mother's systemic immune response disrupts the delicate, finely timed choreography of neurogenesis and synaptic pruning.
What specific pathogens are we talking about in this model?
A classic epidemiological example is the influenza virus. Data from multiple countries over decades has consistently shown that birth in the winter or spring months following the peak of flu season is a modest but robust risk factor for developing schizophrenia later in life.
It's incredible.
The prevailing hypothesis is that a maternal flu infection, an orthomyxovirus, during the second trimester, causes an inflammatory cascade that fundamentally increases the vulnerability of the fetal brain to developing severe psychiatric illnesses like schizophrenia or bipolar disorder in early adulthood.
And what about viruses that do crop the placenta and directly attack the fetus? We all saw those heartbreaking images of microcephaly during the Zika outbreaks a few years ago.
Zika is a virus related to dengue and West Nile, but it is uniquely capable of vertical transmission across the placenta. Congenital Zika syndrome results from the virus's direct, devastating toxicity to the neural progenitor cells, the stem cells forming the fetal brain. It halts brain growth, causing severe microcephaly, profound intracranial calcifications, and devastating motor and cognitive deficits that become starkly apparent as the child attempts to meet developmental milestones.
Rubella used to be a major cause of congenital issues before the widespread use of the rubella vaccine, right?
Yes. Congenital rubella syndrome is a classic teratogenic infection. If a non-immune mother is infected with the rubella virus in the crucial first trimester, the virus causes devastating developmental disruption. Beyond the classic triad of cataracts, deafness, and cardiac defects, it causes profound intellectual disability, autism spectrum presentations, and severe behavioral challenges, including marked aggression later in childhood.
And lastly, in this group, a bacterial example, Listeria.
Listeria monocytogenes is a ubiquitous bacterium often ingested via contaminated soft cheeses, unpasteurized milk, or unwashed produce. While it causes a mild gastrointestinal illness in healthy adults, pregnant women are highly susceptible.
And what does it do to the baby?
Maternal listeriosis can lead to fetal bacteremia and severe neonatal meningitis. Even if the neonate survives the acute infection with antibiotics, the long-term sequelae of this severe early life brain inflammation frequently include permanent cognitive impairment and a significantly higher incidence of behavioral problems, clinical depression, and anxiety disorders stretching throughout the child's entire life.
Okay, we have covered an immense amount of ground. Let's pull all of these diverse threads together. We've journeyed through viruses melting temporal lobes, bacteria imitating Alzheimer's, autoantibodies attacking the basal ganglia, and parasites manipulating dopamine. What is the grand integration here? How must a psychiatrist or any medical professional think when faced with these myriad complex presentations?
The overarching clinical reasoning boils down to a core, unyielding rule of vigilance. Infectious causes must absolutely always be considered in the differential diagnosis of any acute or atypical psychiatric presentation. You cannot rely purely on the phenomenological presentation, what the symptoms look like on the surface. Because, as we saw vividly with the great imitator syphilis and with HSVE, infectious pathogens can perfectly mimic primary functional psychiatric illnesses like acute schizophrenia, severe bipolar mania, or neurodegenerative dementias.
So if a patient is sitting in front of you, hallucinating or manic, what are the specific red flags that should make a clinician stop and think, wait, this isn't just a psychiatric break, this is an active infection masquerading as psychiatry?
The red flags are the unifying systemic features across these different pathogens. First, a rapid or remarkably abrupt onset of severe symptoms, like we see in pandas or encephalitis. Second, the presence of systemic medical features, a recent history of fever, a strange rash, a recent tick bite, or abnormal lab results like unexplained hyponatremia or elevated white blood cell counts.
What about their history?
Third, a complete lack of personal or family psychiatric history in a patient presenting with new severe illness. And fourth, pay close attention to the nature of the hallucinations. Primary functional schizophrenia typically presents almost exclusively with auditory hallucinations, hearing voices. If a patient is experiencing vivid visual hallucinations or olfactory and gustatory hallucinations, smell and taste, that points strongly toward a medical or neurologic cause, specifically affecting the temporal lobes or other focal brain regions.
That makes perfect clinical sense. Let's distill this entire deep dive into 6 key takeaways. based directly on the textbook chapter. Number 1. Non-HIV infections alter the brain through diverse, overlapping mechanisms. Direct neuronal invasion like HSV, massive systemic inflammation like COVID-19, or autoimmune cross-reactivity like strep throat triggering pandas.
Right.
Number 2, psychiatric symptoms such as acute delirium, sudden psychosis, or severe treatment-resistant depression may actually be the first or even the only prominent manifestation of a life-threatening infection, as we see in early HSVE or neurosyphilis.
A crucial point.
Number 3, the blood-brain barrier is not an absolute shield. It is vulnerable to Trojan horses, like the infected parasites we discussed carrying SARS-CoV-2 into the brain.
Indeed.
Number 4, autoimmune conditions like pandas show us vividly how simple peripheral infections can hijack specific, distinct brain circuits, namely the basal ganglia, to produce literal overnight profound psychiatric disorders like severe OCD. Number 5, parasites like Toxoplasma gondii provide an incredible window into how pathogens might have evolved to directly manipulate human neurotransmitters, specifically dopamine, to alter behavior and potentially lower the threshold for psychotic illness.
Fascinating area of research.
And number 6, early recognition and a high index of suspicion are absolutely vital. Many of these conditions, like neurosyphilis, Lyme disease, and HSVE, are highly treatable with simple antimicrobials if caught early. Missing them, however, leads to permanent devastating cognitive ruin.
Those 6 takeaways beautifully synthesize the necessary progression from understanding the biological mechanism to applying it in clinical practice.
Before we get to the learning reinforcement quiz, I want to leave everyone listening with a final, slightly provocative thought. We've spent this hour looking at how dramatic acute infections disrupt the brain. But think about the subtle, lifelong chronic effects we've discussed. If latent parasites like Toxoplasma gondii can subtly alter our baseline risk tolerance by tweaking our dopamine, and past viral infections like Epstein-Barr virus or dengue leave lingering immunologic echoes that affect our daily mood and fatigue levels, it raises a profound question. How much of what we confidently call our innate personality or our natural temperament is actually just the quiet, lifelong conversation happening between our brain and our resident microbiome and virome? Are we entirely ourselves, or are we, at least in part, the sum of our microscopic passengers?
That is a deeply profound question. It is the point where infectious disease, neurobiology, and human philosophy completely intersect. It forces us to reconsider the biological boundaries of the self.
Definitely something to mull over on your commute. Now, let's reinforce what we've learned. I'm going to run through 5 single best answer questions to test your clinical reasoning based on the chapter. I'll read the clinical vignette, and the expert will walk us through the answer. Question 1A, 45-year-old man presents to the A&E with an acute onset of fever, severe headache, and a massive personality change over the last 48 hours. The family reports new, bizarre hypersexuality and profound anterograde amnesia. He can't remember anything that happened yesterday. A lumbar puncture is performed. The CSF shows a lymphocytic pleocytosis, elevated protein, and a completely normal glucose level. Based on this presentation, which brain region is most likely being primarily targeted and destroyed by the suspected pathogen? Is it A, basal ganglia, B, occipital lobe, C, temporal lobe, or D, cerebellum?
The answer here is C, the temporal lobe. The presentation of acute fever, rapid personality change, and profound anterograde memory loss paired with a viral CSF profile, the normal glucose is key, is classic for herpes simplex virus encephalitis. Furthermore, the specific symptom of hypersexuality points directly to early Kluver-Bucy syndrome, confirming the strong, specific predilection of HSVE for destroying the bilateral temporal lobes.
Question 2A, 7-year-old girl is brought to the pediatric clinic by her parents. They report that over the course of a single weekend, she developed severe, abrupt onset, obsessive-compulsive behaviors, washing her hands dozens of times an hour, and prominent facial tics. This occurred roughly 10 days after she recovered from a severe sore throat. Her teacher noted today that her handwriting has deteriorated significantly. Which underlying pathophysiologic mechanism best explains her sudden psychiatric symptoms? Is it A, direct bacterial invasion of the frontal cortex, B, autoantibodies cross-reacting with basal ganglia epitopes, C, latent viral reactivation in the trigeminal ganglion, or D, cytokine storm causing global cerebral edema?
The correct mechanism is B, autoantibodies cross-reacting with basal ganglia epitopes. This clinical picture, the sudden overnight onset of severe OCD, tics, and fine motor deterioration following streptococcal infection, is the absolute hallmark presentation of pandas. The mechanism relies on molecular mimicry, leading to an autoimmune disruption of the cortical basal ganglia thalamocortical circuits.
Question 3A. 60-year-old woman with a history of poorly controlled diabetes and severe COVID-19, which required mechanical ventilation and high-dose systemic steroids 1 month ago, presents to the clinic. She complains of severe unilateral facial pain, nasal congestion with dark purulent discharge, and a worsening headache. What is the most likely opportunistic pathogen responsible for her current symptoms? Is it A. Tamia solium, B. Borrelia burgdorferi, C. Order mucorales, or D. Epstein-Barr virus?
The answer is C, fungi of the order Mucorales. This clinical vignette perfectly describes the terrifying onset of mucormycosis. The specific combination of recent severe COVID-19, high-dose immunosuppressive corticosteroid use, underlying diabetes, and localized nasal-facial symptoms is a massive, urgent red flag for this highly aggressive, tissue-invading fungal infection moving toward the cribriform plate.
Question 4A. 30-year-old immigrant, recently relocated from a rural area in Central America, presents to the neurology clinic after experiencing his first ever adult-onset generalized seizure. A CT scan of his head reveals multiple small, calcified intraparenchymal lesions located specifically at the gray-white matter junction throughout his cortex. How was this patient most likely infected to cause this condition? A bite from an infected Anopheles mosquito. B. Accidental ingestion of water contaminated by cat feces. C. The fecal-oral route via close contact with a human tapeworm carrier. Or D. Walking barefoot in contaminated agricultural soil.
The most likely transmission route is C, the fecal-oral route via close contact with a tapeworm carrier. The presentation of adult-onset seizures accompanied by calcified intraparenchymal lesions at the gray-white junction in a patient from a highly endemic region is the textbook presentation for neurocysticercosis. This is caused by ingesting the eggs of the pork tapeworm, Tyrannia solium, shed by another human, not by eating undercooked pork itself.
Question 5F. 55-year-old man is brought to the psychiatric clinic by his wife. She reports progressive, severe memory loss over the past year, new delusions of grandiosity, emotional lability, and a noticeable tremor of his tongue and hands when he speaks. During your neurologic exam, you note pupillary abnormalities. His pupils accommodate to near objects, but they do not react or constrict to light. An MRI reveals diffuse frontocortical atrophy. Which laboratory test is the most appropriate next step to confirm the underlying diagnosis? A. CSF PCR for HSV1.
Right.
Serum VDRL followed by a confirmatory FTA ABS. C. Detection of anti-dengue IgM antibodies. Or D. Blood smear microscopy.
The correct test is B, a serum VDRL followed by FTA ABS. This patient is presenting with the classic signs of general paresis, which is late-stage neurosyphilis. It perfectly mimics a neurodegenerative dementia paired with bipolar mania. The specific pupillary finding accommodating but not reacting to light is the classic Argyll-Robertson pupil. Confirming the diagnosis of this great imitator requires specific treponemal serologic testing for treponema pallidum.
Excellent reasoning. For those of you studying this material, I highly recommend directing yourselves back to the chapter. Read through the specific case studies to really solidify these complex concepts in your mind. Here are the details of this episode.
Neuropsychiatric aspects of other infectious diseases, non-HIV. Byline. Invasion and aftermath when infection unsettles the brain's equilibrium.